This podcast will cover the topic of Rh alloimmunization as it relates to pregnancy. Rh alloimmunization is an important, largely preventable complication of pregnancy related to a pregnant person's blood type not matching that of their fetus. The goals of this podcast are to understand what determines blood type and how the immune system responds to different blood types, to review how this pertains to pregnancy specifically, and to understand how to prevent Rh alloimmunization and hemolytic disease of the newborn. A person's blood type is determined by the presence or absence of A or B antigens and by the presence or absence of rhesus or Rh factor antigens on the surface of red blood cells. The antigens present on our blood cells are determined genetically. Everyone has 2 alleles, one from each parent, determining our ABO status, and 2 alleles determining our Rh status. For ABO blood type inheritance, A or B alleles are dominant, and so all we need is for one allele to be present and the protein will be expressed on the surface of the RBCs. This slide shows the possible combinations of alleles which will result in each of the ABO blood types or phenotypes. Let's look at a couple of examples of possible inheritance patterns for ABO blood type. Parent number 1 is blood type AB, so they must carry one allele for A and one allele for B. Parent 2 is blood type O. This means neither A or B antigens are present, so the parent must be OO. Their fetus may be AO, and so A antigens will be present. This is blood type A. Or the fetus may be BO, and so B antigens will be present. This is blood type B. In this case, parent number 1 is blood type A. This parent could either be AA or AO. Parent number 2 is O, and therefore must be OO. Their fetus may be AO. A antigens are present, so the fetus will be blood type A, or the fetus may be OO, so no antigens are present, which would be blood type O. We then also add in the Rh or rhesus factor. Again, the Rh factor allele is dominant, so we only need one allele to be present for a person to have the rhesus factor on their RBCs, and thus to be Rh positive. An example of a possible inheritance pattern: parent number 1, Rh negative. This means that both of their alleles are negative. Parent number 2 is Rh positive, which means they could be either positive or negative, which is heterozygous, or positive, which is homozygous. Their fetus may be positive negative, and so Rh positive, or negative negative, and so Rh negative. Note that there are several different possible Rh antigens. D is the most common and the most likely to cause problems in pregnancy, as we will learn later on in the podcast. So what happens if our blood comes into contact with blood of a different blood type? Our immune system will detect a foreign protein and perceive it as a threat. As a result, our B lymphocytes are triggered to make antibodies to attack these cells that contain the unfamiliar antigen. In this example, a person is blood type O negative. This means that their own RBCs have no A, B, or rhesus antigen. If they were to come into contact with blood from an A positive person, their B lymphocytes would identify the A antigen and the rhesus factor as foreign, and thus would make antibodies which would attack these foreign RBCs. The production of these antibodies is called alloimmunization. If a person is AB positive, their immune system is already familiar with all 3 antigens, and so they are unlikely to mount an immune reaction to a different blood type. So now that we understand how a person's blood type is determined genetically and how a person's immune system can react to a different blood type, let's look at how this pertains to pregnancy. A few important facts. Fact number 1, a pregnant person and their fetus can have different blood types. We test a pregnant person's blood type in their pregnancy, but we usually do not know the blood type of the fetus. I say usually because if both parents are O negative and both parents are the only possible contributors of the alleles, as in there are no other sexual partners around the time of conception, then we actually know the fetus will be O negative as well. Fact number 2. The blood systems of the fetus and the pregnant person are separated by the placental membrane and do not typically mix. This means that even if a fetus is Rh positive and the pregnant person is Rh negative, which is called Rh incompatibility, no immune response will be mounted during the pregnancy because the blood does not mix. Fact number 3. However, there are situations when fetal blood enters a pregnant person's bloodstream due to a breach in the placental membrane. This is called a fetal-maternal hemorrhage, which can occur in the following circumstances: unexplained vaginal bleeding, spontaneous abortion or induced abortion, traumatic injury, invasive prenatal testing such as chorionic villus sampling or amniocentesis, or during labor and birth. Fact number 4. In the event of a fetal-maternal hemorrhage in a pregnancy where the pregnant person is Rh negative and the fetus is Rh positive, the pregnant person will see the Rh antigen on the fetal RBCs, and their B cells will create antibodies to attack these Rh positive RBCs that have entered their bloodstream. As discussed, this is called alloimmunization. Most commonly, it will be anti-D antibodies created since Rhd is the most common antigen. Fact number 5. In a first pregnancy, when this has happened, the initial antibodies formed are large IgM antibodies that do not cross the placenta to the fetus. But in subsequent pregnancies, when the antibodies present are the smaller IgG antibodies, these antibodies do cross the placenta to the fetal bloodstream and can then attack the fetal RBCs if the fetus is Rh positive. Subsequent pregnancies are more dangerous since the immune system is already primed and will react more robustly and rapidly, producing more antibodies. Fact number 6. If anti-D antibodies cross the placenta and attack the fetal RBCs, the RBCs break down, creating anemia and a release of bilirubin into the fetal bloodstream. This results in a condition known as hemolytic disease of the newborn, or HDN. HDN can range from mild to severe. We may see a mild self-limiting hemolytic anemia, severe anemia with hyperbilirubinemia or jaundice from the hemolysis or breakdown of RBCs, or hydrops fetalis, a condition in utero where the fetus has severe edema as a result of severe hemolytic anemia. Fact number 7. We have been talking about Rh incompatibility and alloimmunization above. Note that ABO incompatibility can also occur when the pregnant person is blood type O and the fetus is A, B, or AB. In this case, it is possible for the pregnant person to develop antibodies against the A or B antigens on the fetal RBCs in the event of a fetal-maternal hemorrhage. This can cause hemolysis of the fetal RBCs in the same way, but is typically a more mild reaction, presenting as mild self-limiting anemia with hyperbilirubinemia in the newborn. So how do we prevent hemolytic disease of the newborn? Firstly, we determine who is at risk by testing the blood type of every pregnant person in the first trimester. We also screen for any antibodies already present. If the pregnant person is Rh positive, then they are not at risk of HDN. If a pregnant person is Rh negative and their antibody titers are negative, they will be a candidate for an injection of Rh anti-D immunoglobulin, or Rhig, which is what we can use to prevent alloimmunization and subsequent HDN. Rhig is given by IM injection to all Rh negative pregnant people at the following times: at 28 weeks gestation, within 72 hours of birth if the newborn is determined to be Rh positive. If the newborn is Rh negative, there's no need for a dose of Rhig at this time. Or as needed at less than 28 weeks if a fetal-maternal hemorrhage is suspected. How does it work? If a pregnant person is exposed to Rh positive blood from their fetus, the circulating anti-D antibody we have administered to them effectively attacks and destroys any fetal blood cells before the maternal system has time to mount an immune response. The Rhig does not cross the placenta and so does not cause hemolysis in the fetus. Anti-D immunoglobulin is only used in pregnant people who have not already been sensitized. What happens if a pregnant person has already developed Rh antibodies and is now pregnant? We first want to determine if the fetus will be at risk by determining their Rh status. Start by testing the non-pregnant parent's type. If they are Rh negative, then we know the fetus will be Rh negative as well. If they are Rh positive and homozygous for the Rh allele, the fetus will be Rh positive. If they are heterozygous, there is a 50% chance the fetus is Rh positive. In this case, we can determine the fetal Rh status by collecting a blood sample from the pregnant person to analyze fetal cells and their blood type. If the fetus is determined to be Rhd positive, the pregnant person's antibody titers will be followed closely. If they start to rise, it is likely that hemolysis is developing. The management of pregnancies affected by HDN is beyond your scope at this time, but it requires close fetal monitoring through our maternal fetal medicine specialists, including potential testing of fetal blood for degree of anemia and possible intrauterine blood transfusions. A newborn of an affected pregnancy will also often require testing for degree of anemia, possible blood transfusions, and often phototherapy or exchange transfusions for treatment of hyperbilirubinemia. Some food for thought. RHIG is a blood product. Pregnant people need to provide informed consent to receive it just as they would for a blood transfusion or to receive any other blood product. Patients who are Rh negative with an Rh negative partner know that their fetus is Rh negative and so can decline the RHIG. But what if the non-pregnant parent is actually not the person contributing the allele? If the pregnant person has had sex with anyone else around the time of conception, then this changes possible fetal blood type. The pregnant patient may not want to divulge this possibility, and we know this occurs at a surprisingly high rate amongst pregnant couples. Some studies cite what is known in the literature as non-paternity rates to be in the 1 to 3% range, while others are as high as 10%. Many centers do not ask for or test the non-pregnant parent's blood type for this reason and simply offer RHIG to all pregnant people regardless. In summary, we have learned about how blood types are determined genetically and how the immune system can react to a foreign blood type, a process called alloimmunization. We have learned how this alloimmunization can occur in pregnancy when there is Rh incompatibility between the pregnant person and their fetus, and when there is a fetal-maternal hemorrhage where fetal blood enters the pregnant person's bloodstream. We also learned that this can result in hemolytic disease of the newborn, a condition that can range from mild self-limiting anemia to severe life-threatening anemia and hydrops fatalis. And lastly, we have learned how to prevent Rh alloimmunization and hemolytic disease of the newborn by administering anti-D Rh immunoglobulin to at-risk pregnant patients at 28 weeks gestation, within 72 hours of birth if indicated by the newborn's blood type, and as needed prior to 28 weeks gestation if a fetal-maternal hemorrhage is suspected.